Hello, here we are again. This is going to be video 5, I believe. It's depression. And I'm going to start off by saying I want you to separate a couple of concepts for me. Not everybody who's depressed commits suicide. Say it aloud. Not everybody who's depressed commits suicide. And not everybody who is suicidal is depressed. Okay, so repeat that. Not everybody who is suicidal is depressed. Make them two separate entities. They do not belong together. And so I'm going to talk about depression, then child psychology, and then suicide because I don't want you to link those two together. Okay? If you do, you'll miss a lot on the test. Suicide is more likely to accompany depression, but it's also more likely to accompany mania, schizophrenia, just about any other psychopathy, antisocial personality disorder, borderline personality disorder, any other psychopathy, not just depression. Okay? So that being said, let's talk about depression. Depression is a mood disorder. I'm not sure which chapter this is in your book, but it's a chapter that's titled Mood Disorders, and you're welcome to go ahead and find that in your book. But 17% of lifetime prevalence happens for depression, mainly women, happening in the mid-30s. There's stats for you. You can look at it. I'm not going to belabor it. It's the fourth leading cause of disability in the United States. So yes, you can get disability for being depressed. It is neurobiological, which means it has to do with neurotransmitters, but it also can deal with your sleep-wake cycles, and it can deal with genetics. Unfortunately, they haven't been able to find the male-aligned genetic code for depression, but they have linked it to diabetes. They've linked it to obesity. They've linked it to, good Lord, hypertension and CHF. So that being said, it must have something to do with your neurotransmitter system that affects those also, and increases in cortisol, which are primary in most of those disease states. Some theories. Freud said depression was anger turned inward and usually related to some sort of loss. Beck said it's just because we weren't thinking right. Of course, I love Beck. Learned helplessness is over in families, over generations. People, mainly women, learn to depend upon the men in their life or their significant other in their life, and thus become this dependent personality type, which has more of a linkage to the moods of depression. So the genetics there, they think it's more of a nurture thing rather than a nature thing. I don't know if I believe that, but I have seen the dependent personality type before. I do know that that's can be a learned behavior. And it's different between cultures too. You have to consider what cultures are more paternal versus maternal, and where the cultures view the women as subservient versus independent. So you have to think about those things and what the person might actually be feeling when they're experiencing that lifestyle. Other things that can lead to mood disorders, life events. I think everybody gets a little depressed when somebody dies. Everybody gets a little bit of a depletion of serotonin. Everybody gets a little bit of depletion when there's a loss of any sort, losing a job, having a divorce. Life events can cause that, but it's not, it's not pathological unless it completely interferes with your ADLs. And then it's a psychopathy. It's a pathological psych disorder. Personality traits can predispose someone towards mood disorders. That's your dependent personality trait, which leads back to the learned helplessness model. Other disorders associated with depression, we already talked about diabetes. We've talked about CHF, some of the open heart issues, like an open cabbage is always prone to depression. neurological, including stroke and Alzheimer's. Those are linked to depression. And there's different meds that you can use to help with that. Mainly the 3 classes of antidepressant medications that are out there. Let's see. Some of the other ones: vitamin deficiency, thyroid states, sleep apnea, cancers. I think the cancer one, I haven't been in cancer for so long. I've kind of had an interest in cancer and fatigue. And cancer and fatigue are strongly linked in the literature, secondary to tumor growth. And I think that has a lot to do with depression and cancer. It doesn't have to do with, oh my gosh, I'm going to die. It has to do with the actual secretion of the tumor, the neurotransmitters that are produced by that. And some cancers are worse than others as far as fatigue goes and depression. So it's an interesting field to study. I think I might be interested in looking into something like that at another point in my life, possibly studying the linkages between depression and fatigue, which could lead to several different disease processes, but that's a different time. Let's talk about the DSM-4 TR criteria for depression. We have to have a change in previous functioning. There must be an impairment, depressed mood, and hedonism, weight loss or gain, suicidal thoughts, insomnia, hypersomnia, psychomotor agitation or retardation, decreased concentration, indecisiveness, anergia, which is a lack of energy, and worthlessness or guilt. Now, 3 or more of those within 6 months is considered diagnostic for depression. And you can see a lot of them are opposites. So weight loss, weight gain, sleeping a lot, not sleeping enough. So it's an alteration in daily function that has to do with your resting cycles, or your energy cycles when you're producing energy, such as feeding. Let's see. Depression's very interesting. You have alterations in thought and mood, behavior. You can have physical changes. So you need to assess the general criteria, as in which I've discussed before in Chapter 8. But you also need to assess their support systems, probably more heavily than other support systems, because this type of personality, or this type of person, is less likely to seek out help. And you need to help them identify what is out there for them. They may not even realize what kind of support systems they have. So we're going to look at relationships. We're going to look at their self-care. A very good nursing intervention for somebody depressed, plan of care, would be impaired hygiene, secondary to fatigue. Okay. So you would look at that and you would say, okay, how am I going to qualify this? How am I going to get them to do something? If you can get them to get up and walk to the bathroom and wash their face, you have done an amazing job. That's a perfect example of one intervention you can do for depression. Oftentimes they don't even have the energy to move while they're in bed, so they'll lay, putting them more prone for ulcerations, impaired skin integrity, and things like that. But that's really severe depression. Self-assessment, oh yeah. I know a lot of nurses, they think, gosh, if they just got up, got cleaned up, they feel so much better, and that's just not true. All of their happiness in their life, all their serotonin in their brain is just not working the way it needs to work. And when it's not working the way it needs to work, getting up is a chore. I mean, it's like rolling a boulder uphill for them to move. I had a patient tell me one time it was like falling into the bottom of a well, and you scream and scream, for maybe 1 or 2 minutes, and then you realize that nothing is ever going to pull you out of that well. And so you just lay at the bottom of the well and you wait to die. Now, granted, she was an older person, and I have a well, so I understood that analogy, and maybe you don't, but it's a great big hole in the ground, and you just sit there, and everybody's walking around, and nobody can hear you, and nobody can see you, and nobody understands what's going on with you as you lay in this bottom of the well. So it's kind of a normal expectation that we expect people to take care of themselves and get up and let's go, come on, let's move. You got to do something, shake it off. But for depression, that's just not. So you have to realize for yourself, when you think those things, they're wrong. You need to change the way you're thinking, and you need to say, okay, they can't do that. Now, I'm not going to do for them, but I will do up to a certain point to encourage them to do for themselves. So maybe they can't wash their face the first day. Maybe you wash their face the first day. The second day, you hand them the washcloth. Them holding the washcloth possibly could be a big step. Then eventually, maybe on the third day, they're able to maybe touch their face with it, wash a few places with it. That's good. We're moving forward. Small steps. So just remember that. You have to remember that we have to be patient, very patient. Depression requires the greatest extent of patience that you can have as a nurse, because it will take 15 minutes, 20 minutes sometimes for them to formulate a thought and to get it from the tangles up here out their mouth into you. And all that time you're sitting there with unconditional positive regard and genuine empathy and leaned in, good nonverbals, listening. Let them know you're actively listening to what they're saying or what they're about to say. And then don't think, oh my gosh, what am I going to say if they say I want to kill myself? Don't think like that. Just wait and listen for what they're going to say to you. In depression, there's an acute phase. It lasts about 6 to 12 weeks, and this is where we start the antidepressants. You want to get them going as quickly as possible because it could take up to 12 weeks for them to work. And that's unfortunate because after you begin giving them the antidepressant, one of the first things that they feel within about 2 weeks is energy, and they start to feel better. And when you give them enough energy and they're still depressed, then they might suicide. So within 2 weeks of starting antidepressants is a very high risk period for suicide. If you manage to make it through that, we're moving on to 4 months to 9 months. We're going to be titrating the medications up or down depending on what we need to do for their symptomology to increase their quality of life. And then if they're on it, up to 1 year and more, because they'll be on it for life if they're truly depressed. This is something that's not going to go away. It's a chronic illness. And we're just going to keep on the medication for as long as we can. Now, over time, the unfortunate thing is that most of your antidepressants will lose power, which means they could have relapse. If the depression is severe enough, we have to consider ECT therapy in addition to medications. Sometimes we can use anti-seizure medications to help with mood in addition to antidepressant therapy, or we can use antipsychotic medications. Abilify is the one that comes to mind, in addition to their SSRIs, which are the most commonly prescribed antidepressant, and rightfully so, because they're missing serotonin. Let's give them serotonin, make them feel better. But a lot of those therapies, you want to wait to that post-year, 5-year. And in the meantime, we can do things like keeping them calm, use cognitive behavioral therapy, support groups. I always hear helpless, hopeless. They feel helpless, they feel hopeless. Having hope is very important for life to exist. People have to have hope. They have to believe in something, which is where a lot of your religions come from. It's a bonding belief. You have to have some hope, or existence seems futile sometimes, especially to the depressed patient. So that's where you're going to see more and more of them leaning towards that suicidal ideation. Moving on, how do we talk to them? The easiest way to talk to a depressed patient, the easiest way to talk to anybody with a psychopathy, when you first walk up to them is you make an observation. You seem deep in thought if they're sitting there with their eyes closed. You seem sad today. You appear asleep. Let's talk. That kind of thing. and sit down with them. You want to use simple words, allow adequate time, and I've told you that's really a challenge for you probably. Listening for the covert messages. Covert means hidden, so listening for any kind of disguised language such as the world would be better off without me. They're not coming right out and saying they're going to commit suicide, but ask about suicide plans. Don't avoid platitudes. Don't say, "Oh, you're going to be just fine. It's going to be perfect. Don't worry about it." No, that's condescending to somebody who's depressed. It is, you're not giving them permission to feel the way they feel. And they're like, fine, they think it's going to get any better. It's not going to get any better. I'm going to go hang myself. So don't do that. That's just not a good way to go with them. Like I said, ECT works really well. That's electroconvulsant therapy, shock therapy. You may have heard that. It works. There's a couple of hyperlinks there for you on the next slides. You're welcome to look at that. It kind of tells you how it works in the brain. What it's designed to do is like a reboot or a hot boot of the brain. Reset it. It's a very safe procedure, not the way it was way back in the day. Back in the day, it was awful. They didn't sedate them. They tied them down, put in a bite block. They shocked them, and it was just awful. They'd have burns from the electrical going into their brain. They would have seizure activity. They would have, seizure activity is desired, but they would have all sorts of horrible side effects afterwards, and just the trauma of being physically restrained was not cool. But ECT kind of works like antidepressants. I don't know exactly what the neurochemistry is in the brain. I don't think anybody does. But it's like a reboot. It's kind of like a reboot, getting you more of your neurotransmitters, especially serotonin. Usually it's a course of treatments. We have somebody who comes to St. Rita's usually every 3 months, and she swears by it. She says without this, her depression would probably have caused her to suicide many years ago. So she's on antidepressant medication plus ECT every 3 months and does quite well with it. If the groups here at St. Rita's get to experience that, I know Dr. Bruno loves to do teaching. He'll bring you right down to the procedure suite, and you can watch. So it's also used for schizophrenia, mania, and some other mental disturbances. Nursing care for ECT, it's relatively simple. It's pre-op, post-op care. They come in, it's usually done outpatient. They come in, you pre-medicate, you do your vital signs, their NPO, you accompany them downstairs, you do your whole checklist thing. If there's an IV that's needed, you put that in, pre-surgical or pre-procedure. You accompany them downstairs. Restraints are put on 3 limbs. Usually 1 limb is left unrestrained to observe for seizure activity. They are anesthetized. They're put to sleep. The electrodes are put onto the head so they can monitor brainwave activity, and then the shocking pads are put onto the head to prevent electrical burns and things like that. And then they go ahead with the procedure. In the meantime, the physician is in a back booth, and he's watching the brain activity. He is watching what happens after so many joules are delivered, seeing for the reset, looking for the reset, when the brainwave activity alters, and then he stops the procedure, and they come back to the floor. They're still NPO. Usually they're because they've had a seizure, they're postictal, so they're kind of got a little drool, and they're really sluggish coming back. So once they can drink, once they can swallow, once they can get up and go to the bathroom, once they're back, they may have some memory loss issue with it, and that's okay too. That's common. Then they go home. It's real easy. So vital signs, you're going to watch them just like post-op care. You're going to watch your level of consciousness. Like I said, they're going to have some memory loss, headache possibly, confusion. If they're a little bit bigger person, you guys should know this, the bigger the person is, the more anesthesia it takes. If they're a little bit bigger person, it may take longer to come out of the anesthesia, so they may have some logginess, or maybe a little bit difficult to get back out and back to normal. When do we not want to use ECT? Well, I don't want to give somebody a shock therapy treatment if they have a brain tumor. Okay, I don't want to give anybody a diagnosis of schizophrenia or depression if they have a brain tumor. So that's one of those things you have to rule out before you even give them that diagnosis. Oftentimes, cardiac disease is not going to stand in the way. It depends on the severity of the cardiac disease. If someone had a CABG 25 years ago and their vessels have remained clean, surprisingly, but they've remained clean, and they're on cardiac medications for arrhythmias or things like that, the doctor may not go up in the voltage as much as he could, but he probably would still do ECT. Likewise, if they're taking anti-seizure medication, the desired effect is a seizure. So we either have to increase the voltage beyond what is an acceptable level for the anti-seizure medication, or we have to decrease the anti-seizure medication prior to ECT to elicit the correct response. The latter one is usually what they do because it's safer. But they don't, there's no absolutes. They won't say, okay, we're not going to do this just because you're on, because you have epilepsy and you're on these anti-seizure medications. We're not going to do that. So it just depends on the doctor, and we have some good doctors around here, psych doctors, who know what they're doing with that. So finally, we're to the drugs. I love it. There's many different classes of antidepressants. Like I said, SSRIs, the first-line agents, and some newer atypical antidepressants. Those are the ones that are used the most commonly. The other antidepressants are the SNRI, serotonin norepinephrine reuptake inhibitors. That's Cymbalta, Effexor. Those guys, they think serotonin and norepinephrine are needed. Okay, we really don't know what causes the defunct in the chemistry. We know serotonin's the big one, but maybe norepinephrine too, to help with the fatigue and increase their activity. Second line interventions, we can do tricyclics, we can do MAOIs or monoamine oxidase inhibitors, and then ECD, and then there's some Deglin L-methylfolate preparations that are out there, but they are the last resort, even below ECT. Let's see. The next slide is just a little picture showing you how the reuptake inhibitors work. They're allowing more of that neurotransmitter to live in that synapse between your axon dendrite and your receptor sites where it's going to suck it in, or your dispensing in that's going to reuptake it or suck it back. So the idea is we want more neurotransmitter living in the synapse, no reuptake, so that when the receptor sites on the receiving end are saturated, they've used their medication, they're open again, they can resaturate, and we can continue to provide increased levels of the neurotransmitter that are needed. MAOs, they don't use a lot of them anymore, and I'll tell you why. It's because of the horrible diet that goes with them. You can't have anything aged, you can't have any chocolate, no wine. Pepperoni is out on your pizza, so nothing processed. The one that I have seen, and I actually have a patient that takes Nardil, and he's a younger man because his depression was so severe. He was on an SSRI and Nardil was added. But he's accustomed to the diet at this point, and so he's really not going to hurt himself. If you have a little old person in the nursing home who's on Parnate, and that's where you'll see it, is in the nursing home because it is so old. They really are not able to eat, mainly because of tyramine. Tyramine is processed by your MAO, monooxidase neurotransmitter. And when we inhibit that, we get increased levels of tyramine. We have increased levels of tyramine that causes malignant hypertension, and it can cause a stroke and a lot of problems, especially in that population who are already at risk for those types of things. You got to be very careful. MAO inhibitor prevents destruction of norepinephrine, serotonin, dopamine, increases levels of those neurotransmitters. So that's how it works for the good. So the inhibitor blocks the destruction of those things. Tricyclics. Tricyclics are used a couple of different ways, primarily for depression, but they also work really well in preventing diabetes neuropathy. So you may see somebody who is not depressed actually using a tricyclic inhibitor because of their peripheral neuropathy. I'm thinking of Elavil. That's the one that's used most commonly. Tofranol, Pamelor, you see that in the nursing homes. They're second oldest class. The reason that they're out there used like that for depression is they're still useful. They still work. The bad thing about them is that they're sleepers, so you want to give those at nighttime before they go to bed. Really helps with sedation. The mechanisms of the tricyclics, they block the reuptake of norepinephrine and serotonin, so we have those two neurotransmitters increasing in activity. And then finally, we're to my favorite class. And we're going to pause here for a minute.